streaming at the moment as well. We're live streaming on YouTube as well. Hello, everyone around the world. I see that participants are trickling in. Thank you for joining us today for this very important topic. We have a TBPPM webinar. My apologies. That was the echo. Hello, everyone around the world. We're officially starting with this webinar. We have a webinar where we will be talking about shorter tuberculosis regimens, a really important topic. We have a great presentation lined up from TAG, and we have a large panel of private providers that is with us today to discuss about the importance of shorter regimens for their patients and for people that are affected by TB. I'm really pleased that today's webinar will be moderated by Dr. Jennifer Furin. Dr. Furin is a physicist. She's also a specialist in infectious diseases and a medical anthropologist. She works at the moment at Harvard Medical School and is very active in collaborating with many operational organizations such as MSF on the ground, and has a wealth of experience in clinical practice and in public health that she's sharing with the world. And I'm really pleased that she is leading today's webinar on behalf of everyone. So Jen, I'm handing over to you.
Great. Well, thank you so much for that very kind introduction. I think what you said in a nice way is I've been working in TB for a long time and I'm old now. It's really good morning, good afternoon, and good evening to everyone. It is really such a pleasure and a privilege to be here with you all in the audience, but really with this distinguished panel of providers. I've been a TB doctor now for almost 30 years. And I have to say, I think that we are living in a time where there has never been so much promise and hope in the TB space. We're now able to prevent TB and treat TB infection with regimens lasting as little as a month. People who are sick with strains of drug-resistant TB can now be treated in 6 months with 4 drugs. And people who have drug-susceptible TB are looking at a much shorter regimen as well, only 4 months. And while we know there are many things that contribute to making treatment tolerable, that duration is definitely one thing. That really impacts the lives of people who are living with TB, because when they're on treatment, their lives are really quite disrupted. And so I think all of us here share the same vision of a world where no one is sick with or suffering from or dying from TB, and that one of the best vehicles for getting there is through the use of these exciting, new, shorter, more effective, and more tolerable regimens. But we also know that we have to work together as a community, and a really important community that we are excited to spend time talking to today are the community of people who work in the private sector. And our colleagues who joined us are often providing care to people who really seek them out. And so making sure that we embrace their perspectives and the services that they provide as we strive as a global community to get access to these exciting, newer, shorter, more tolerable regimens is a really important part of making sure that everyone who is impacted by TB has access to the best services available. So I want to thank my colleagues who are joining us from really all over the world. We have Dr. Akram, who's joining us from Rawalpindi in Pakistan. We have Dr. Sandesh, who's joining us from South India. We have Dr. Raibi, who's joining us from Nairobi, Kenya. Dr. Rastogi, who's joining us from New Delhi, and Dr. Tebelele, who's joining us from Port Elizabeth in South Africa. So we have really a huge wealth of providers who are joining us from all over the world to share their perspectives. But we also have joining us Mr. Pervez Chivile, who's going to be speaking. He's also from Pakistan, but is a TB survivor and the director of the TB People program there. And right now I'm going to turn it over to my colleague, Mr. David Brannigan, who's the TB project officer with the Treatment Action Group. And he's going to present to folks about this very exciting campaign to make sure we roll out with some sense of urgency these regimens. And he's going to talk about the 146 by 24 campaign. So I'm going to stop talking now so that we can hand over to David and then get talking to our panelists. But we hope this will be an exciting morning, afternoon, or evening for you all, where we can really help kick the momentum forward. So thank you in advance to everybody. And David, over to you.
Thank you, Jen, so much. Hi, everyone. As Jen said, my name is David Brannigan. I'm the TB Project Officer at Treatment Action Group. And I'm very happy to be presenting to all of you today on the 146 by 24 campaign to scale up access to short course regimens for TB prevention, treatment of drug-sensitive TB, and treatment of drug-resistant TB for everyone, everywhere. And this is a campaign to bring together the TB community to rally the energy, political will, and funding that we need to end TB. So why do we need this campaign? The TB response experienced a lot of challenges and backsliding in recent years, in part due to the COVID-19 pandemic and related disruptions. And this continues to threaten our progress in the fight against TB. We've already missed nearly all of the treatment and prevention targets set during the UN high-level meeting on TB in 2018. And to get back on track, we need an infusion of energy, political will, and funding. And this requires something inspiring to rally around. And as Jen mentioned, after more than 20 years of research and development, we can finally treat TB infection in as little as 1 month, and most forms of drug-sensitive and drug-resistant TB in 4 and 6 months. Yet, relatively few people have access to these shorter regimens. And this lack of access constitutes really a human rights issue and should inspire outrage. So these are some models of what it would look like to implement a comprehensive TB interventions to end TB by 2030. And this kind of pink line along the bottom is that's mass vaccination. So that will really turn the tide. But short of that, with the technologies that we have better technologies to diagnose, prevent, and treat TB, fully implementing those, we make a tremendous amount of progress in reducing the burden of TB. And one of these lines here, it's hard to see, but it's the blue one, is public-private mix. So we're all a part of this vision, this potential to really end TB. So what does 146 by 24 mean? So 1 month is once weekly treatment regimens, 1 month or once weekly treatment regimens for TB prevention. 4 is 4-month treatment regimens for drug-sensitive TB. 6 is 6-month treatment regimens for drug-resistant TB. And by 24 is by the end of 2024. So we want this to be our deadline, our collective deadline for having in place the staff, space, systems, and support that's needed to really scale up access to these shorter TB regimens and make them accessible for everyone, everywhere as a human right. Additionally, part of the campaign is filling research gaps. There's a number of priority areas. We want to be able to extend the benefits of these shorter regimens to all groups, some of whom cannot currently access them due to the data gaps or research exclusions, including children and people who are pregnant. So pre-2016, we were treating TB infection with 6 to 36 months of isoniazid preventive treatment. And then also a 6-month regimen for drug-sensitive TB, and then 18 to 24 months of taking medicines for drug-resistant TB. But now we can treat TB infection in as little as 1 month, or 3 months, drug-sensitive TB in as little as 4 months for adults and kids, and then drug-resistant TB in as little as 6 months. And so looking at the time saved, this is a really good visual. You can see what impact this will have on people who have TB or who are at risk of TB and are taking these medicines, and then also what impact this could potentially have on health systems. And so the shorter regimens mean that people and families affected by TB are able to get back to work and school sooner and recover economically. People affected by TB, they find the treatment to be more safe, tolerable, and acceptable, which would lead to fewer treatment interruptions that could generate resistance, higher rates of treatment completion, better outcomes. And then also the human resource and other health program savings from the shorter duration of prevention and treatment regimens can be repurposed to other areas of the TB response. And so this campaign is inspired by the late Paul Farmer, who believed that everyone everywhere should be able to benefit from the latest biomedical interventions and receive the highest standard of care. This is also reflected in the Universal Declaration of Human Rights and the right to science. The governments have a duty to make available and accessible to all persons without discrimination, especially to the most vulnerable, all the best available applications of scientific progress necessary to enjoy the highest attainable standard of health. And so in order to do this, we need to get the staff, space, systems, and support in place. The 146x24 campaign is not just about having the technologies, but making sure that they're implemented and made accessible. It's about claiming the right of people with TB to enjoy the benefits of scientific progress, and generating the energy and political will needed to end TB. So this is also inspired by the 3x5 initiative, in which the WHO and UNAIDS sought to provide HIV treatment to 3 million people in low and middle income countries by the end of 2005. And that campaign generated a tremendous amount of investment and political will. And so 146x24, this is our moment in TB to get back on track to ending the disease. And so for staff, that includes the care providers, doctors, nurses, community health workers, staff, the diagnostic tests, corresponding consumables, medications, other equipment, space, appropriate dignified care facilities, systems, policymaking and regulatory mechanisms, other services, support, accompaniments, the things that patients will need to get better, such as food, housing, counseling, and other psychosocial services. And this approach requires a multi-sector and fully financed TB response. So the campaign is bringing together all different actors across sectors, and asking them to make commitments to contribute toward making this toward achieving 146x24. And for national governments, we're calling on them to expedite the uptake of new innovations through rapid updates of national guidelines, strategic plans, essential medicines lists, and ensure there are healthcare worker trainings on short course TB prevention and treatment regimens, increase domestic and international investments in TB programming, leverage legal and other strategies to help improve access to TB medicines and diagnostic technologies, and then develop patient-centered models of treatment and prevention that deliver care through differentiated community-based systems, including for post-TB support. For donors and other funding mechanisms, we want them to increase investments in TB programs to support higher medicines costs and increase health systems and human resources, laboratory infrastructure, and diagnostic technologies that are needed. Also to expand existing sources of funding to support civil society and community organizations in countries to work on national 146x24 campaigns and accountability initiatives, and to expand the resources and capacity to accelerate research to fill data gaps and to shorten treatment even further. For pharmaceutical and diagnostic companies, we are calling on them to develop fit-for-purpose formulations for the short-course prevention and treatment regimens, including fixed-dose combinations and formulations appropriate for children, also fit-for-purpose diagnostic technologies, including rapid molecular tests and tests for drug resistance, particularly to the key medicines rifampicin, isoniazid, fluoroquinolones, and bedaquiline at the point of care. Also, rapid registration with stringent regulatory authorities and WHO pre-qualification, transparent evidence-based pricing determined by the cost of goods sold, plus a reasonable profit, or to patent non-enforcement to make sure that these technologies will be accessible and affordable, and also to commit to filling the outstanding research gaps. And for research networks and institutions to implement the studies needed to fill these research gaps, to advance the research needed regarding these fit-for-purpose regimens and technologies, and then ensure that the regimens are safe and optimized for all populations, including people living with HIV, adolescents, children, pregnant people, and then evaluate other risk factors of people who would benefit from treatment extensions, evaluate preferences and needs of target populations, and then invest in developing better point of care TB diagnostics and new TB vaccines. So for all healthcare providers, which include you who are joining us today, it's important to demand access to these new innovations through rapid updates of national guidelines, strategic plans, and essentials medicines lists, and also to implement healthcare worker trainings on short course TB prevention and treatment regimens in order to expedite uptake in the private sector. And then also mobilize through your healthcare professional associations to network, inform, learn, share information, have discussions, and then build a collective commitment to implement 146 by 24 by the end of 2024 in the private sector. And to demand the legal and policy frameworks that can help improve access to the TB medicines and diagnostic technologies, and actively demand patient-centered models for treatment and prevention, and link up with the programs that are able to deliver care through differentiated community-based systems, including for post-TB support. So key opportunities that we're looking at in the campaign, include having national governments, figuring out where they're at in terms of implementing the short course prevention and treatment regimens, elevate the campaign to the attention of the Minister of Health and other duty bearers, national strategic plan development, making sure that the new regimens are included in that, making sure there's sufficient budgetary appropriations for implementing the new regimens. There's Global Fund funding requests, which is a real key opportunity to get funding to support the scale up of these regimens, and then engaging really all stakeholders. So I think with this, I just want to share, we have some resources in these slides with a lot of background regarding the regimens. These are the landmark studies that generated the evidence in support of the use of these shorter regimens. And then all of these regimens are recommended by the WHO, and these are links to all of the guidance. So I just want to clarify again, I'm from Treatment Action Group, but the 146 by 24 campaign is run by a coalition of organizations, some of which are listed here. So thank you everyone so much. It was a pleasure to present. And with that, I'll hand it back over to Jen.
Great. Thank you so much, David, for that very exciting and comprehensive tour through the 1x4 by 6 by 24 campaign. I think when we look at TB and where we have been and where we have the potential to go, we're really on the cusp of something amazing right now. And I think the campaign gives us the structure around which we can now target all the activities that we need to undertake. So it's very exciting to see it presented this way. And I just want to mention for all the folks who are listening or joining the webinar that the links to these resources are posted, and that if you need or want more information or some of the resources that David mentioned, that all of that is available online. And so thank you for that. And, I think that, again, with many hands, we can make our work lighter. And I'm excited to see comments from some of the participants as well, that people are ready. We're ready to advocate and make these changes happen. These are not changes that are just going to trickle down. And if they do, it's going to take many decades. And we know now is the time. So I think it's very exciting. And while many of us are looking at the potential for what this means in terms of transforming the way that we practice, I think the most powerful voices that will drive much of this change forward are going to come from people who are impacted by TB, who've survived TB, who are living with TB. And so it gives me great pleasure to turn now over to my colleague, Pervez Tufail, who's joining us from Pakistan, who is a fierce advocate for the rights of people who are living with TB and who heads the TB People organization there. And we really want everyone to be mindful as we think about going through this, what these changes could mean for people who are impacted by TB. So Pervez, I'm going to turn over to you to hear your perspective before we start moving to our panelists.
Thank you so very much, Dr. Karen. Thank you for the wonderful participants, and thank you for everyone who is listening here. So just one minor clarification. I am originally from Pakistan, but I live in the United States. So I'm working all over the world, and I am also working with the survivors. So before I go into my discussion, I just want to add one more S, David. You said that staff, space, system, and I want to add one, which is survivor. So TB survivors are probably one of the key lead in this whole process, and we are very much thankful for this shorter regimen, and we are very excited, and we are also anxious and worried. Why we are anxious and worried? There are many reasons. So it mostly happens, like I personally, from the patient perspective, believe that no providers understand the pain a person go through the TB processes. Every time when we as a TB survivor, I try to avoid using TB patient for me, as this is a kind of stigmatic word. So I usually use either TB survivor or person with been affected by TB. So I will be using the term TB survivor for this discussion. So we as a TB survivor personally feel like translating the recommendation from the research into the practice is a wonderful initiative. We are really excited to see those recommendations into the practical processes. But the question is, if we will be having, like, for example, if we'll be having 100,000 people, survivor, who are looking for transition from 18 months to 6 months or even 4 months or 1 month, well, are we ready to provide them all the services which they are looking for? I'm talking about the availability and accessibility of the services. 2, the TB survivors, they are illiterate, they are living in remote part of the world where they just heard that this transition happened and 18 months converted into 6 months. So they all are running for that shorter regimen. But at the end of the providers, they probably, as a survivor, I feel like they're probably not ready to tackle that huge bulk of transitioning from that perspective to this perspective. So they are still going through the guidelines revision process. Like, for example, we have 3 types of guidelines here. We have CDC guidelines, we have WHO guidelines, we have national guidelines. We need to standardize all those guidelines as quickly as possible, and we should be moving from words to action. And the action is, we need this shorter regimen now, so we can save the lives of those who are going through this whole hard process. And like, when we visit to the healthcare providers, most of the time they are even not knowing what the current regimens are available, and this lack of literacy usually happen into the process where patient or survivor go through another layer of the problem. And another challenge which we feel like is, like, when we are listening that the shorter regimen is available and we are approaching to the provider and demanding that shorter regimen, they mostly say that, oh, you are MDR, but you are MDRR, you are not qualifying for this shorter regimen. So this qualification is another question and challenge for the survivor. So the provider who are specifically the technical expert here, they should also clarify who is eligible and who is not eligible for the shorter regimen, because this is very much clarification needed. Because when we are asking for the shorter regimen, we should be very clear who we are asking for, what we are asking for, and who is the provider in that process. And the third one is like, we need resources, as David mentioned already. We have national guidelines, and the revision of national guidelines is a long-term process. And for that process, we probably need to have resources which could help us to revise the national guideline and take into the practices. And probably I'm having shorter time, so I will try to be very squeezed. So, and at all this point, as David said, we need to have patient-centered. I'm saying that patient-centered because we feel like we are part of the system, we are part of the process, and we are centered. If we are not satisfied whatever this happening is, we probably not having the required result. So we want to be engaged in all the process from conceptualization till implementation. And we are really happy to be part of the process. We are ready to shake our hands with the researcher, with the provider, with National TB Control Program, with WHO. We are ready to offer our technical support. I usually call that we are the doctor from the library, from the community, from the practices. We are also aware of the challenges which we face. So we need this as quickly as possible, but we also need literacy. We also need to know what's happening around. And one key component which I usually feel like is missing is the counseling and literacy for the TB survivor. Most of the time, TB survivors know they are having TB, but what sort of the TB they have? Is this MDR? Is there NRI? Is this susceptible? It's like latent, it's infection. So this they are very much confused about that. So I would suggest that whenever we are visiting the survivors, they should educate us properly. They should guide us the way we want their guidance, and they should also give us this impression that we are from them. They should not give us the impression that, oh, you are someone from the alien. We are not alien. We are part of the process. We have the right to survive. We have the right to life, and this is our human rights. We need this all process as quickly as possible. And finally, I just want to recommend the national governments. The national government should put more investment in this all revision and converting this recommendation into practicality. They should be procuring the shorter regimen as quickly as possible. And like, for example, BPOL, we are hearing a lot about that. But is it available? It is provided. Providers are having access to it. Are they recommending it to the TB survivor? Are they practically giving it to the survivors? These are the questions. So let's work together to make this world happy, free of life. And I'm very much sure that I will be seeing TB free world in my lifetime. And I believe that nothing us without us. We are part of the process. We are part of the solution. We are not part of the problem. Let's work together so we can share our perspective. We can have the provider's perspective, and we can move forward collectively. Thank you so very much for this opportunity to share my perspective.
Thank you, Pervez. It's wonderful to hear from you. And I think, you reminded us, right, that the importance of how we move forward in TB is really not necessarily just about the regimens and the pills, that it's really about partnership, right? And we often, even in this webinar series, we focus on sort of the public-private partnership. But what we really need to do is engage more in partnership with people who are impacted by TB, that this is really about what they bring to the table and what we bring to the table, and how we can maximize each other's roles as we move forward with rolling out these exciting new regimens. And yes, TB is a source of significant suffering, but the only way out of that suffering is through a true partnership with each other. And so thank you. I think that's a great way to frame our discussion moving forward. And so we have a lot of people to talk to today, you know, their bios are posted online, and I'm not going to reread those to you because I actually want to hear what they have to say about things as we move forward. And so we have a number of questions and topics that are going to be guiding our discussion right now about these newer, shorter regimens for TB prevention, for drug susceptible TB, and for drug resistant TB. And so I'm going to call on certain panelists. I promise we'll hear from everybody, but you know, rather than go through the list of everybody with each question, I thought it would be nice to hear perspectives from different regions of the world, from different types of practices. And so I'm actually going to start by asking Dr. Sandesh, who's joining us from India, what are you most excited about when you think about these new regimens? Maybe you can share with us a little bit about what's exciting to you about that.
Oh, well, thank you for calling me as a panelist. First of all, this is the first time I've been with you, and it's so exciting. Well, shorter term is something which is more exciting. The time itself is more exciting. We being the doctors, we would love to short the duration of sufferings of each TB patient. And this is a wonderful opportunity for us to shorten the duration of sufferings of all the TB patients and give them a complete cure. You know, I've been through a lot of patients who are with MDR TBs. You know, like they're really frustrated. They're really frustrated that treatment never ends. You know, like most of them become defaulters, and this is something which has come up, a ray of hope or a ray of light, which they can really catch up and get a cure. So if the program is implemented in a proper way, and if it reaches everybody, I think this should be a game changer in TB. And as Parvesh told, I think we all will see a TB-free world in our lifetime only if it reaches properly.
It's very inspiring to think about that this is something that's within our reach, and that with our actions and our work, we can get there. Dr. Tevelele, you're joining us from Port Elizabeth in South Africa. What are you most excited about in terms of these shorter regimens? You're on mute, Dr. Tevelele. You're on mute.
Thank you very much, Jennifer, and greetings to all the panelists all over the world and all our viewers. It's a very exciting moment, especially for South Africa, to be part of the global movement. It's a very exciting times to have this shorter regimen, especially noting that our country, South Africa, is battling with a high number of people who are lost to follow up. We've got a very high rate of defaulters. That is people that we lose in the follow up of TB treatment. So shorter versions of treatment means there will be less of that. We are likely to have more people completing the treatment. That should be very exciting. And the shorter regimens will also have a high burden of HIV. And if you talk TB, you can't talk TB alone. You talk TB together with HIV. Those are terrible twins. People are already on treatment, and then you add, there's high pill burden. So the shorter the regimen, the better the adherence or compliance. That is exciting. And also as a private provider, we are more like assisting the public. So we are decongesting the state. If you look at the 2006 guidelines in South Africa, anyone who's diagnosed with TB would have to be given a letter to go to a clinic or any public outlet. But the presence of private providers in the treatment and management of TB means less burden to the state, and private providers are more available to the patients, and they've got better relationship. just to look at the reporting, if you were to get some of the report from the Eastern Cape, you would find that 95% of the patients that were treated privately, they completed their treatment. There is less likelihood of loss to follow up in the private sector because the working hours are more flexible. Patients are more likely to see us after working hours and also are available on weekends, unlike clinics that are closing at 4 and they are not available on Saturdays. So the shorter regimen also means less side effects. In fact, more people are likely to comply or adhere to treatment because the painful injections, especially if you talk drug-resistant TB, the painful injections as the route that South Africa is more likely to take is the 6-BPAL route, including MOXIE. That is the route that the national government is endorsing. So it means they have painful injections and their side effects are going to be a thing of the past. So patients are more likely to comply. That is exciting with the new shorter version of the treatment. And having mentioned the HIV and the high burden of TB, more people are likely to access TPT, that is TB preventive therapy. And that will actually dent the incidence of TB. So we're likely to get less new infections of TB because more people are likely to, the uptake of TB preventive therapy is likely to be higher because it's shorter version. That is the first one out of the 146. The number one is likely to improve things for us in terms of incidence, in terms of adherence, in terms of spreading more TB. And then having been in the private sector, the issue of stigma in the public sector, they are queues for TB patients, or there are designated areas where TB patients are this side, HIV patients are this side, whereas in GP practices, there is no such distinction. Patients are queuing in one area, there's less stigma and less discrimination and no segregation of patients. So patients are more likely to go visit private practitioners than they were doing, and they're more likely to comply with more private practitioners involved because of the relationship, because of less stigma, because of the attitude. Whether we like it or not, there's one thing that will always come up when it comes to management of TB and HIV, the staff attitude. Private people are more trained on customer care. Hence, if you look at the statistics that we've produced in the Eastern Cape, you'll find that more patients completed their treatment is because of the staff attitudes. No one is rejected and people are trained on customer care. And there are other advantages that if this can be escalated to involve more private general practitioners in terms of investment, because the shorter versions of treatment means there should be more access to drug susceptibility testing. Everyone should have access to GeneXpect, which is not the case in South Africa currently. So we need more funding in that area of space. My colleague has already mentioned that there are newer versions of investigations. For example, WHO has approved the stool GeneXpect for children. It means we are more likely to pick more TB from children because it's always a struggle to diagnose children with TB. So South Africa is more likely to benefit not only from the newer or shorter versions of treatment, but also from the investigations, the availability of investigations. But the issue is some of the drugs that are on these newer versions of treatment, they are still pending sub-trial registration, which is something that needs to be fast-tracked. So one homework that we'll have is to make noise and encourage South African government to fast-track registration of some of these drugs so that TB can be less of a burden and more people can be able to access the shorter versions of treatment. Thank you for now.
Thank you, Dr. Tevelele. You've given us a lot of meat to work with there. And I think, hearing about how these shorter, more tolerable regimens will really improve the ability of people impacted by TB to finish their treatment and be cured is exciting. And I think also hearing about, some of the benefits in the private sector, including flexibility of care and integration of care, also give us some important lessons for how the public sector can be offering better services. So with those bits of excitement, because I think we could probably talk for years about how exciting it is to have these things, I'd like to move to Dr. Akram, who's joining us from Rawalpindi in Pakistan, to hear maybe a little bit from you about, what are the plans in Pakistan for including private providers like yourselves, and what are your plans around some of these shorter regimens? If you can tell us a little bit about that and what kind of help or support you might need as a private provider to have access to these things for the people that you're serving.
Thank you, and thank you everyone for joining this session. And I'm very excited to let you know the issues we are facing over here in the terms of treatment, everything. I'm the medical director here in a private hospital, and we are the first one in the whole Pakistan who are doing the public-private partnership with the Green Star and the Mercy Corps. I'm facing some kind of issues like number one, we are providing the free of cost medication for the global funding and everything. But the thing is that like there were the services in COVID-19, we were very much focused, the world was very focused on prevention. I do think that we didn't focus towards the prevention. First, we wait, there's the patient with the tuberculosis to be diagnosed, then we get after that. But there should be something like educational. The doctors and the paramedics are working in the smear positive wards without mask. And the prevention is better than cure, and we need to focus on that. The second, the social media and use of the social media, like all over the people and the accident people are sitting together today. We can discuss our many issues together, and we can sort out that. The third one is important, the counseling of the patient. The patient who are feeling insecure because of the stigma and in here that's prevail in our society. And the fourth one is that the services of the tuberculosis that we help through the physicians or the diagnostic, they are too scattered in Pakistan. And these scattered services results in the distrust on the treatment protocols. I'm giving you an example. There is the MDR center that is established in Murray. It is in a hilly area of Pakistan. That's right now the temperature is -3, and that is not provided with the heating and cooling. When the patient will be there, and they will, how they can approach there. And the third one is that we are facing some kind of diagnostic challenges, like one center is provided with a gene expert, and other center is having not like their services, the pulmonologist. And I think when in COVID-19, what we do, our government was doing in Pakistan, they are very excited to treat that disease. We were doing the geotagging. And what is the geotagging? That someone is being diagnosed, that with label on, we can relate that, and we can refer to the respective GPs which are nearby to them. And the third one is that there should be more focus on the contact tracing. We treat the patient. Anyone you can treat the patient. Even now, the program is so broad, and even the doctor sitting in America can treat the patient here in Pakistan and even the other countries. There should be another issue. There should be the monthly audits. Other doctors, and Dr. Sultan Haider and Dr. Pervez from Pakistan will agree with that. The GPs are either they are working very great, but there should be a system. We should address the issues that the doctors are facing and others, the patients are facing regarding treatment complications. And we are less likely very far behind to address that issues. And the third one is that I'm very excited to see this program of the shorter regime having the results and implementation and the future benefits. What happened in Pakistan, especially one thing I want to mention, when we have using the longer regime, what happened, there is a two other systems also results into hindrance to treatment. One is the alternative medicine, that is the Hakimic medicine, and other is the spiritual practices. And when the patients go towards them, they relate everything, their improvement to that discipline of their treatment. They are less likely inclined toward us and from the local GPs and the consultant physician. Anyhow, we are working when we are today we are all over the world are together. I'm so hopeful and I'm very excited to see, and in future we can help each other, and we get know the everythings and the new guidelines and the improvements of the patient. And thank you everyone, and you people are the real power. Everyone will be safe only when the other patient of the tuberculosis will be treated. That should be the motto. And thank you everyone.
Thank you, Dr. Akram, for that perspective. I think you've highlighted some really important issues there. And one of them is about these exciting shorter regimens. But I think one of the reasons the campaign focuses not just on the treatment, but sort of the systems and the stuff, we do see that people who are impacted by TB often face myriad other problems. And while TB may be top on our list of things, if you don't have heat and it's freezing cold outside, it's often very hard to prioritize taking TB treatment. And so these shorter regimens are certainly a step in the right direction, but we definitely need to think about these other aspects, these other systems, this other stuff that will help roll out these regimens. So thank you for reminding us of that.
Thank you.
I want to turn to Dr. Rastogi, who's joining us from New Delhi, and I would love to hear your perspectives as a private provider in India about what some of the plans there for including healthcare providers like yourself in the rollout of these shorter, better regimens. So over to you, Dr. Rastogi.
So yeah, thank you, Jennifer. So as the other people have already mentioned about that, how indeed it's really exciting to be a part and to introduce these kind of 146 regimen in our country, because coming from honestly a TB capital country in the world, so the major things which the long-term therapy has in the entire practices is, of course, there is a much issue with the adherence. Not only with the young population, but also with the patients who are specifically having a lot of comorbidities, because there's a lot of drug interactions and all, and there's always a disruption of the treatment. And whenever there is a disruption of adherence, that begets the resistance for sure. And of course, with these kind of shorter regimen, I'm really excited that for an individual itself, it will prevent in the dissemination to the other parts of the body, but also apart from an individual, it prevents the dissemination to the other people as well. So this is really exciting for me to be looking about these kind of advantages of the shorter regimen. And having said so, the lesser side effects, that is a major challenge when we give a long-term regimen, because it comprises of 6 to 7 drugs, specifically in the MDR regimen. And one or the other, either it's a very good synergistic, but at the same time, there are a lot of side effects which are mind-boggling and creates a lot of issues. But having said that, the only thing is that with this shorter regimen, like we have discussed about the lot of S's, I want to just highlight about that we need to be more sustainable, and more than that, we need to be more stringent when we are talking about the shorter regimens. So as Dr. Parvez has mentioned about the integrated regimen, because in our country, the national guidelines play a very important role because of the free of cost services and the more subsidized cost of services, especially the TB drugs giving. So in that scenario, we need to be too late in giving them these kind of services at a very immediate effect, because the more delay we have, the more resistance we are actually getting in. Second of all, since the bacterial infections, because the moxifloxacin and linezolid, these are the compounds which can be even used for the bacterial infections, and coming from the MDR prone categories, so very stringent diagnostic and especially at the field level diagnostics have to be really picked up, so that we can have a single point orientation and a more proper inclusion criteria, that whom not to be offered and whom to be offered this kind of a shorter regimen. And of course, I would really be excited to know about the validation and the usage in the extrapulmonary TB cases as well, because as far as PTB is concerned, the EPTBs are equally important, specifically after post-COVID, We are seeing a lot of EPTB cases. So yeah, and last but not the least, the more vulnerable group, because they are also at a very, very high risk of, MDR tuberculosis specifically, the immunocompromised people, more than 60 plus. So how these shorter regimen will be really excited in terms of compliance, but at the same time need to know about their status as well. So yeah, thank you.
Great, thank you, Dr. Rastogi, and thank you for bringing up some of the populations that were not included in some of these studies. I think later on in the panel, I want to hear from people. Dr. Tebelele mentioned children. We heard about elderly people, people with extrapulmonary disease who are at risk for being left behind, and would love to hear from you all how you want to and plan to include those populations. I want to turn to Dr. Haider now, who's also joining us from Pakistan. And I'd love to hear from you, Dr. Haider. Are you being included in these discussions about some of these new regimens and how they're being rolled out in Pakistan? Is the private sector part of these discussions? Are there plans in your practice and clinic to have access to these regimens? What can you share with us in that front?
Thank you very much for having me. The private sector, we have a lot of bureaucratic red tape over here. So if you're going to say that we as a private practitioners are responsible for the policy making, maybe we are not that much. But we are working at our place in our capacity as well. And the private practitioners, as Dr. Tebelele said, we are the first line where every patient has to come and they has to come with us. So that sets the tone of the patient. We sending a patient to a government facility or tertiary care. It is much better that we treat the patients towards in our own clinics as well. And actually when I started when we were doing the house officers, at that time we were shoving 10 or 12 tablets inside in the patient, counting the rifampicin, counting this. Then FDC concept of the game, actually. They made treatment much better. And it was 9 months. Then it came 4 months. Now 1 month. 1 month would be like, we cannot say, because if you take it from the perspective of a patient, it is something very good. And the rest, we as a physicians, as family physicians, what we have to do, we are doing is, we are trying to educate the patients, patient screening, their contact screening, these things have been happening. But policy making and these things, I think they are at that level that we can affect in a small instance of the government. But policy making is over here, I think is not much more of a private practitioner's game, more of a. And rest, I'm extremely excited because of 1 month is, I don't know, we have been treating people, these patients, and we should more be interested in children as well, because children over here is the neglected part. Then pregnancies, the women, over here in our part of the world, they don't even take any medicines. They avoid taking medicines. This is taboo that they are taking medicines. TB itself is such a big taboo over here. If you tell someone that you have a tuberculosis, most of the families, they try to get rid of the patient, or they try to get in rather than getting them getting treated at home. So it's good. But one thing is, with the last year, we were introduced with free availability of Gene Expert. That changed the game a lot. But we need better tools, because without tools, it's useless. We can have the best medicines, but if we are not able to diagnose the patient, what's the fun of doing that? So we have to have a very, very, very aggressive approach towards tuberculosis in our countries which are endemic, Pakistan, India, and Africa. We have to be that, right? And I think we should set a much more stringent and a much aggressive manner over here, and we should be making this 1 month treatment as soon as possible available over here. Thank you.
Great, thank you, Dr. Haider. And I want to ask Dr. Raibi, who's joining us from Kenya, if your audio and has connected now. You know, what is it like for you there in Kenya as a private provider, hearing about these newer regimens? Are you going to be able to access those and offer those to your patients? If you can share your thoughts, Dr. Raibi.
Hello, everyone. My name is Daisy Rioba. I'm a clinician from Coptic in Kenya. Personally, we're excited because as it is right now, we are already using the 3HP. So we're looking forward to start using the 1HP. Personally, here we provide the drugs for free because we receive them from the government for free. So we are not worried about our clients not getting the medication. We're also happy that it may improve the adherence to the newer regimens, and also it may reduce the stigmatization that usually comes with the medication, especially taking medication for 6 months. That's quite a long time. And also, I'm so sure it will improve the uptake among healthcare workers, because personally, I work at the CCC Center. So we see a lot of TB clients. So it would be a good idea for healthcare workers to do the uptake, to improve the uptake of the new regimens that are coming in. Thank you.
Great. Thank you so much for sharing that perspective. We have some questions from the audience that maybe we'll start, Dr. Sandesh, with you. So we've heard a lot of excitement. We've heard a lot of the needs and why these regimens are going to be good for the populations that we're working with. But one of the questions that is coming from the audience is, what are the logistics for you now? You've heard about these regimens. Are you able to offer them in your practice? And if not, what kind of logistics need to be solved, and what kind of support can we as a group think about putting into place? So over to you, Dr. Sandesh, on this question.
Yeah, logistics are really a question, because any new regimen that comes or any new drug that is introduced, it requires some amount of logistics that should be travel everywhere, because a drug that is denied is not the drug of choice at all. So if you deny a drug, you know that the drug is not available, then there is no point in somebody providing you, telling that this is a 100% cure when it is not available. So availability of the drug is the most important aspect of any campaign or any drug regime that becomes popular or that becomes more effective. Now, coming to the second point, most in the place where we work in India, where we work, most of the drugs are from the RNTCP, that is Revised National Tuberculosis Program. So unless the government makes it very accepts this and makes all these drugs available to nook and corner of the country, it becomes very difficult for us as a private practitioner. Yes, to a certain extent, in a bigger cities, in bigger places, metropolitan cities, we can make the available drugs in the nearest pharmacy or maybe in the hospitals. But the real problem is there in the rural population, where you have to penetrate deep to cut down the roots of this TB. So if this program has to be effective, then I personally feel that the government has to take it in a bigger way. The drugs has to be available everywhere. And the second thing which I normally feel is the testing methods. The testing methods need to be very effective to the ground level. And as all your S's are there is one more S. I feel that the selection of the patient is very important. You know, you select the patient in a proper way, whether she's pregnant, whether it's a kid, or whether it's an MDR TB. We need to select the patient in a proper way, and appropriately we may have to give the treatment in such a way that it is made easily available. One of the most important failures of why we get a lot of MDR TBs is basically because of non-adherence. Our primary treatment of immediate drug susceptible TB fails, and that's why we land up MDR TBs. Now, why the drug susceptible patient fails is basically because of non-availability of the drugs sometimes. So availability of the drugs, the logistics, everything has to be maintained in a proper way. And this really needs to be done fast. Unless and until we do it fast, I think our program might not be such effective. So the primary point of everybody who's sitting here is to make sure that we need to pressurize the government or anybody who's there, our colleagues, to make sure that this kind of a treatment is available, and that needs to be all the drugs that are there, that needs to be available at dispense for the needy patients as soon as possible.
Great. Thank you so much, Dr. Sandesh. And I think, it's a very important point, right? We can have beautiful guidelines and we can have wonderful studies and policies, but we really do have to make sure that people on the ground are being served, that things are working for people on the ground. And so I just want to mention a couple of points and get to a few more questions. So, I think one of the things we're all excited about is having new regimens, but we also, I think, need to focus on a frame shift in how we think about TB. And I think one important part of that is just to make sure we're not using stigmatizing language. And so I thank our participants for pointing that out, and that, these are people who are impacted by TB, people who were lost to follow up, et cetera. So I think all of us can make a commitment today to being more mindful in how we talk about our partnerships with that. You bring up an important question and point, Dr. Sandesh, which is, these drugs are not available. And so we're all reliant on government to make them available. But there's a question that came up in the chat that I'm going to post to Dr. Tebelele, which is, do you think private providers should be providing care? I think sometimes in TB, we want everything very stringent. We want a very strict system. We think that that's going to stop some of the problems that we end up seeing. But I was really taken by what you said earlier, Dr. Tebelele, about the flexibility and the integration and the sort of mindset of being of service to people and working with them. So maybe you can give us your thoughts on, should these drugs be made available? Should private providers be treating people who are living with TB, and help answer the question that was raised by one of our audience members?
Thank you, Jennifer. My feeling is very clear. If I were in government, or if I was a CEO of South Africa, I've been involved with TB since 2010 as a private provider, but we've been getting support from NGOs. NGOs come through government, of course. We have been in the era of getting support from TB Reach. I've been in the era of getting support from Equity. Currently, we are getting support from Equity. Of course, what is making GPs frozen is because there's little funding, or sometimes no funding. For example, in the Eastern Cape, it's only the Nelson Mandela region that is getting benefit of PPMs, TBPPMs. But we would love that at least there is many all over South Africa. So there's definitely a need for more general practitioners or private providers to be involved, noting the outcomes. 95% success rate, and the public sector is struggling with the loss to follow up patients. The numbers are escalating almost every day. And the more people we lose in the management of TB, the more we're going to battle to contain the burden of TB. So for me, more general practitioners involved, more private sector, especially in view of the current move in South Africa towards the national health insurance. If you invest on TB in this way, involve more private practitioners and more practices, that is practice and keeping people fit for what is coming in terms of NHI. There can be no success in NHI, especially looking at primary health care, if there is no involvement of more GPs. So more resources, more access to GeneXpect, more access to TB testing, and more access to drugs, the more we are likely to dent the incidence and the burden of TB.
Thank you, Dr. Tebelele. It's all hands on deck, really, isn't it? We are living at a time when we could do so much more for TB. So why would we want to keep anybody out, right? Particularly people who are very focused on service provision, flexibility, integration. I want to move back to
Jennifer, just one more point to add.
Please.
There's a lot of administration on TB. There are so many registers that one has to go through. But now you'll have an advantage of having every general practitioner will be trained on what each register means and to provide healthcare workers to support. There's a moment when we were with TB Reach where we were sending healthcare workers to go and screen patients at home. And then we got a lot of TB out of visiting patients at home, and then we manage those. So more support, more investment on administration that is planting resources and searching for TB, because there are people with TB that is asymptomatic. The fact that now TB has been revised in terms of radiology is available as part of screening, that is an added advantage, but make it more accessible to more private providers. Then you will see movement. Just provide support, plant more funding, you will never go wrong. Just look at Port Elizabeth, you will see the results. Thank you.
Outstanding. Yeah. And I think even new ways of doing things, right? These registers that all of us sort of, like I've spent half my life, I think, filling out forms and registers sometimes, but we learned during COVID about real-time reporting and, how to do these things in a more streamlined way. And so I think that can be part of the stuff and the systems that, David mentioned at the beginning. I want to move to Dr. Rastogi again briefly. The time is just flying by, but you mentioned your worries about the people that you're working with who are living with extrapulmonary TB, and we've heard from several providers about children, pregnant people, people who are marginalized. Like, how do you think we can include them in these innovations? The guidelines say we don't have any information about these populations because they weren't included in studies, and yet these people come seeking care. So what do you think we can do, Dr. Rastogi, to do a better job with these vulnerable groups or groups that aren't being well served and included?
Right. So the point is, Jennifer, so the whatever drugs we are actually including in even a shorter regimens, they are anyways a part of the protocol previously as well. It's more of a cohesive combination which we are trying, except one or two new drugs like the pretomanid, etc. But apart from that, the rifabutine, the rifampicin, the pyrazinamide, isoniazid, moxifloxacin, linezolid, they have already been there in the regime on the board. So the best way out is, of course, the more better diagnostic way, because these vulnerable age groups have a major issues with their subtle features, which is very difficult to pick up from the diagnostic perspective. And same goes for the extrapulmonary tuberculosis, when I was worried about, because many a times they came up with so vague manifestations that it's very difficult to, first of all, pick up at a particular point of time to offer them the first of the course of treatment. So I presume that with these drugs already on board, we know so much about the individual drug per se. It's easier to include them, and I would really love to hear from the other people as well, and would be glad to see these people getting included so that they can also be benefited by the shorter regimen, because extrapulmonary also gets a halt because of its longer duration. You have to have a clinical radiological resolution in terms, and then go about 18 months, 24 months, especially the spinal, the CNS. So would really be excited to take care of these patients specifically in the shorter regimen.
Thanks, Dr. Rastogi. And Dr. Hyder, you also mentioned children as a concern that you have. What do you think we can do to include more children in these innovations?
Jennifer, I think all of us will agree that it is the most difficult tuberculosis to diagnose is of children. They are not compliant and treat as well because of the compliance of treatment. The parents have to do that. To include children, we will have to be very aggressive. We will, again, I emphasize on tools, because without tools, it's absolutely useless working. We have to get better tools. We have to educate the parents that tuberculosis in children is possible. Tuberculosis in pregnancy is possible. Unless and until we do that, our efforts will at a time hit a current population, a specific population we are treating the adults. Pediatric tuberculosis is very difficult for a general practitioner as well. We are, all of us who are working over here, we have such a number of patients that if you will ask us that we can give 5 minutes, 7 minutes, 10 minutes specifically to a patient, it sometimes becomes very difficult. For a kid to diagnose, we need to have better x-rays. We need to have something which can take the sputum out much easier rather than nebulizing them and doing this. These things we desperately need better tools over here. Obviously, we need better education as well for the parents, for the physicians as well. And I think on the part of a lot of us, including me as a family physician, we are not that open to pediatric tuberculosis ourselves as well. A kid comes with cough and fever, we just treat him for a small, give him an antibiotic, he gets well. After 3-4 weeks, he again comes to us. So we have to be very, very, very aggressive. In pediatric tuberculosis, it's very aggressive. We should at the first instance, if we are suspecting tuberculosis, we should go for it, especially in an endemic area. I'm not talking about your part of the world. Our part of the world is entirely different from your part of the world in such situations. So we need to be very, very aggressive, and training at the level of healthcare providers like us, training at the level of our nursing and paramedical staff, that should be done very aggressively, and it should be promoted as well in government setups, in social media, and on television, whatever we can do as an effort for that. But again, we need to be very aggressive and need to have better tools to diagnose pediatric tuberculosis.
Thank you, Dr. Hyder. And I think we all hear you about, having a fire lit under us to do this. We're nearing sort of the final stages of the webinar, and I'm going to ask each panelist before we finish to tell us what they're thinking about, what they're going to do differently after today to make these regimens more accessible. But I think Madhu and I have a connection, because I see his hand up, and I was going to actually ask you, Madhu, because we've heard from a number of panelists today that diagnosis is a problem. And we've heard this outside of this webinar too, that uptake of these newer, shorter regimens isn't happening because people aren't coming to be diagnosed. So I was going to detour to you as our diagnostic, person with a fire lit under him to maybe tell us your perspective on that a little bit. And then also with your hand up, if you had some other thoughts you want to share before we return back to the rest of the panelists. Over to you,
Thank
Madhu.
you, Jen, and thank you to all the panelists. It's really inspiring to see the interest. I genuinely don't believe we can scale up these short regimens if we are still stuck to sputum smears. I just don't see it happening. The fact that in 2023, in a world that has done billions of PCRs for COVID, how on earth do we justify still using microscopy for tuberculosis? Where have all those machines and PCR technicians gone? Have they disappeared off the face of the earth just because COVID is not a problem anymore? They're all there. The machines are there. The technologists are there. We're just refusing to divert it to detect tuberculosis. So to me, I refuse to believe that this is just a technology or a resource issue. I don't believe that's the case. Take India alone. India alone has done 850 million COVID tests and PCRs. How do we then justify continuing to use sputum smears in India for a vast majority of people, where we're consistently missing TB, missing pediatric TB, will never detect drug-resistant TB? We are sunk if we hang on to sputum smears. So please push everyone in your country that we have to transition to large-scale molecular diagnosis for TB. That's how drug resistance opens up. That's how we will at least detect rifampicin resistance quickly and get people on the right regimen. And the other comment I had was more a question for Jen. Jen, couple of things that people consistently bring up when I discuss the short regimen is, one is the 4-month regimen in contexts like India. There's so much quinolone abuse and resistance that the immediate response is, oh, this can never work in our context because it's just too much quinolone resistance, right? So I want to know, as an expert in this area, what should our response be to that commonly raised concern? The second thing is for the 3HP, again, in countries where there's so much malnutrition, India again is an example, some people think that the high dose INH is very, very poorly tolerated in people with extraordinarily high rates of malnutrition. So what would for those two technical questions, how would you answer them as an expert?
Yeah, thank you so much, Madhu. And it sort of comes back again to this idea that innovation needs to be embraced. We have to stop doing things the old way in TB. And yes, you know, if you're going to put someone on a regimen that contains a fluoroquinolone, it's probably a good idea to know if that fluoroquinolone is going to work. And so better access to rapid drug susceptibility testing has to go hand in hand. And, you know, when we were thinking about and planning this campaign, many of us were like, well, we want to have something like to push us like 3x5 did. But we know it's not just about a 1, 4, 6, right? And that's why, again, David put it so well. This is about wraparound services. This is about making services more appealing so that people want to find out if they have TB. They want to be tested because they know they're going to get excellent care. And so, you know, the diagnosis and not being treated with drugs that your strain is resistant to is really part of that. So, and then, you know, I think sometimes in TB, you know, we have lore about, you know, what we're willing to tolerate and can tolerate. If our patients are so malnourished that once a week of INH is going to be too toxic for them, we need to think about how we're supporting people with their nutrition, right? We can't just say, well, I'm not going to do this shorter regimen because it'll cause too many side effects. We need to say, wow, people need nutritional support. How can I help find that in the community? How can I advocate for that as part of the stuff and the systems? You know, and then we need to have an informed conversation with shared decision making with people about, you know, what the risks are and what the benefits are. And we don't do that in TB. We're not used to doing that. So, you know, I think we could probably continue talking for hours about this, but one of the things I like in webinars like this, it's just such a wonderful way to meet other colleagues who care about TB and doing something about TB. But I also like to leave saying, okay, based on this, you know, really exciting conversation, this is something I want to do differently, or I want to do today to think about making 1, 4, 6 a reality in my practice. So Dr. Akram with us from Pakistan, what are your thoughts today after this webinar? What kinds of things do you want to do? And then we're going to go through everybody. I want to close by hearing from all of you what your plans are now for making 1, 4, 6 or one part of this a reality in your setting. But we'll start with you, Dr. Akram.
Well, I want to mention there are other doctors they're facing the issue with the diagnostics. I am the director at the medical, there's a private hospital, but here we have not these issues. Like in October, we did 3119 free of cost gene experts, and there were 46 were positive. In December, we did 267, and there were 47 went positive. My point is that first we do the microscopy of all these patients, then we do the gene experts. There are the two services. There should be something like that. If we are running the microscopy and the gene expert both, then why not only gene expert? There should be the centers to be graded as level 1, level 2, level 3, level 4. And these all centers should have such kind of guidelines. Number second, my point is that in my center, we are providing the free of cost radiological services, even the CT scan. Then, even then, what is not in the air, what is not visible, that can't be approached to the local patients. For example, in the case of the polio campaign, no one can expect they can refuse to have a dose of polio because the government is so much after this polio. They are too much on the toes regarding treating the getting eradication from the Pakistan regarding TB. They are too much serious regarding treating the dengue. The government should have to come forward. Second, what the problem we do face, any patient we diagnose that never come back to us because there are some kind of NGOs involved through the Global Fund. They do moderate all the 6-month process through them. Of course, they would have some kind of complication. They would have some kind of the label. They want to listen from the doctor. They are not TB free. And like in the hepatitis C treatment, when we treat a patient, there's always a follow-up, 6-month follow-up. There should be the 6-month follow-up that we provide free of cost and to all the at our institute. There should be the follow-up so that we can rule out MDR TB. And one more question, and that's my last one question. For example, if the 4th-month regime got failed, then what? We will give the drugs in the continuation phase, or what we will do there? Thank you.
Yeah, thank you, Dr. Akram. And I think I love the idea of making our services so appealing that no one would want to stay away, right? That everyone would want to come and have this done for them. I think we always have to have contingency plans for when people are not able to be successfully treated, right? And I think sometimes in TB, we tend to blame and castigate the patient. And we have to be careful about that, right? There will always be a portion of people who our regimens aren't successful for a variety of reasons. And I think having contingency plans, if someone's not cured with the 4-month regimen, and that's where, again, this joint training, these joint discussions with the public sector so that we have a unified approach and people are getting high quality of care everywhere is really important. So I want to go back to Kenya, to Dr. Ribo. What are your plans now after today for thinking about these shorter regimens? You mentioned in Kenya you're already using the 3HP, which is exciting, but like what are you going to do differently after today, and how can we help as a community?
Okay, thank you very much. Like we had earlier discussed, we are already reusing the 3HP, which we are so proud of, because at least for now, currently, since we're in the CCC department, for all the clients we enroll, we have to screen for TB and we have to initiate them on TPT. That is a given. Now, to what we are going to change, I think as much as we're looking forward to the new regimens, I think we also need to work on some barriers that we have. For example, whenever we get patients who are bacteriologically confirmed, we do contact invitations. So I think we're going to be more aggressive. So we do better follow-ups and follow those contacts so that we may do better screening and start treatment early enough. And like we also said, we're already providing free services. So I'm hoping the government stays the same and continue providing the free services. That way we can be able to provide services to a larger population. Also, we're planning on doing more trainings and sensitization of the TB and TPT to healthcare providers and also to our patients, because it's very beneficial for also our patients to know the benefits that come with it. I think the rest has been said. The only thing I can add is I think we are going to do better and be aggressive on screening the vulnerable population, including orphans and the street kids, because we've already started doing that. So I think we are going to do better and also do even more active case findings so we can rule out the TB. Yes.
Great. Thank you so much.
That is it for me. Thank
That's
you.
exciting to hear. And I love your term contact invitation. Right? We're so used to these very sterile terms of investigation, and then we wonder why nobody comes. I love it. A contact invitation to make it appealing.
Yes.
Yes.
Thank you.
Thank you. So Dr. Sandesh, over to you. What are your plans now for 1x4x6 in your practice?
Oh yeah, definitely. It's a new armamentarium in my treatment regime. I can definitely use it. First, I'll make sure that the things are available. The logistics, as we spoke about, are available in a proper way. Because I've been involved in one of the bigger trials of WHO, that's the PPP, the Public-Private Partnership. My hospital was also involved, and we have done it quite successfully. And the place where I normally practice is one of the places where TB and private are going together hand in hand. I think it should not be a big issue for me to make sure that these drugs are available and it's made to the public and my patients receive it in a proper way. The second thing is, you face challenges. Challenges are common. Whenever a new thing comes, challenges are common. As Dr. Madhukar said, side effects, adverse effects are quite common. We need to face it. It's a way of journey. You keep, whatever that is given in vitro, in lab, the adverse effects might change its course because of the mutations, because we may fail in the treatment. These are all a part of what you have started. Now we need to face that. We need to counteract all those things. When such things comes, we need to again get back together like this and discuss as to what is the next plan of action and come up with it. So I would definitely start. I would be exciting to start the whole regime in my place. Definitely. Thank you for very much.
Thank you, Dr. Sandesh. And I love to hear how already existing relationships are going to be leveraged to roll out this innovation. And how about you, Dr. Tebelele in South Africa? What are your plans after today?
Thank you, Jennifer. In fact, I've already started. I'm tweeting a lot of what is happening in this webinar. That is already a social campaign has started. I've shared the live stream on my page, which has got a huge following and attention of some of the government officials and people who matter, and also patients. The patients have got access to the information that there's a new TB thing. Now, once people start talking in ranks, in boardrooms, and wherever, then there's a new shorter version of TB treatment. When is it arriving in South Africa? When are we starting about it? So I've started creating noise. And also, thanks to the invitation, I started engaging some of the local leaders and social partners and stakeholders to see how much do they know about 14624. There's something called PE Health Forum. They had a TB meeting yesterday. So I spoke to one person in the National Directorate. That is where I got the information that South Africa is already aligned. There are steps, but we are not going to be moving as fast as we wish because of the funding. And the price of rifampicin is actually very, very high. And some of the things that they are still negotiating. So there's a lot that I'm going to do in terms of making sure that the stakeholders, like currently, we are working with Kusela under Equity. I also engage them. How far are we in terms of preparing for this thing? So I've already started and I will continue with that so that they start moving in that direction, especially on screening, aggressive screening. I like one of the speakers who has mentioned that we cannot rely on sputum smears only. We applied so much energy and brains on COVID, and yet TB, in fact, TB is so unfortunate. TB receives less attention. HIV received attention ahead of TB, and COVID received much attention ahead of TB, but still we are remaining with TB as a burden. Now it's high time we focus more resources and more energy and more resources on TB and support NGOs, more funding, and then that is where I'm going to be making noise. Fortunately, I do have some slots on radio, TV, and also my social network. So I will be part of making that making sure that the campaign is well known and is mobilized as one of the advocates of the shorter version of TB treatment. Thank you so much.
I love it, Dr. Tebelele, making noise. We all need to make noise. HIV got attention because they made noise. COVID got attention because they made noise. And we've been wanting these regimens for years, and here they are. So we're ready to make some noise. So Dr. Rastogi, just a final quick thought from you. What are you going to be doing there?
Yeah, so fortunately, in a corporate setup and a part of the National Tuberculosis Elimination Program in our country as a public-private partnership, we have already started mobilizing in this direction. So one very important thing, like you have already mentioned, that we need to be really more loud and more access to large. So one very important thing is that surveillance and tracking system really needs to be very much upgraded, because one patient of TB, more the contacts we pick up, the more early is the window to start these kind of shorter regimens, which can actually bring a lot of good success in terms of the patient itself and of course to the other people. And having said that, the integrated planning, because the society plan, and along with that, the corporate plan, because we need to have either the too much over availability of a drug or too much conditional access. That really needs to be, cohesive and more considered to bring it on the action. Yeah.
Great. Thank you so much, Dr. Rastogi. And then Dr. Hyder, just very quickly, what are your plans? You're on mute, Dr. Hyder.
Actually, it was a pleasure to hear from everyone around, especially all of us seems that we are all in the endemic areas. We are facing almost the same problems. Even in Africa or India, wherever we are facing. I think we will have to be more aggressive, and we should, especially in the adult population, we should concentrate on PCR. That is the only way forward right now. X-rays, obviously, they are, but PCR is the only way forward. Secondly, I have come to the conclusion of hearing all of us guys that those who are working in bigger centers, they are much equipped, they are much better. Those who are working in small environments like us, private clinics, we are lesser equipped to handle these cases. Thirdly, if we had treated tuberculosis like we treated COVID, it would have been over, I think, 5 years ago, 10 years ago. So we have to be very, very vigilant, very, very aggressive. We should take tuberculosis first in every case that we get. I'm going to put it on my first or second diagnosis list. So whenever a patient comes and it seems that he has tuberculosis, I'll go for it. We don't need to wait for it. And we are very grateful for the funds we are getting for the PCR and everything, that we are providing free PCR here in Rawalpindi. That is also a very big thing. And because these countries, places we are working, we cannot provide free medicine from our pockets. And if government is not giving these private NGOs, whoever they are supplying, we will always be grateful to them for these treatments. But rest is, we should make more noise, we should be more aggressive. I think that has been said. I don't need to repeat that. Thank you very much.
No, thank you. And I can't believe how quickly the time went, but we're at the end of our webinar now. And I just really want to thank all the panelists and our presenters. This has been an incredibly fruitful discussion, but I think an incredibly inspiring discussion as well. And I think, this campaign is something that we can all rally around.
Jen, can I?
It's time. Yes, please. Sorry. We really have like just one more second, so I'll give Pervez the final say, but really just thank you to everyone. So Pervez, you can go ahead and close us then.
I just want to highlight one observation. This always happened with the community and TB survivors. So I am not a doctor. I'm a TB survivor and I do not understand technical language. So as like the practices, even in this seminar, I feel like I was less represented. I was not giving appropriate time to reflect my perspective. So this happens every time when we are sitting in a meeting like this. Mostly technical doctors, experts, researchers, they talk about technical language, technical skill. And in this seminar even happen, we assume every attendee is the technical person understanding technical language. This is very, very important key challenge. We need to involve TB survivor actively, effectively, and meaningfully if we want to make this world TB free. This is one. Two, I personally believe like we need to have more activists within the TB survivor and people with affected TB community like HIV/AIDS. If we do not have activists within that group, this movement might not be going forward. And thirdly, is like we should bridge the gap between the service providers and the TB survivors. Every time when there is a gap, the survivor use technical language, give prescription, treat the patient based on the symptom, and they leave them on their own. So please, my request is if you have involving the TB survivor in any kind of meeting, discussion, seminar, give them proper time. Listen their perspective. We love to know about the research. We love to know the new diagnosis and everything. But if we do not understand, if we are just talking about the technicalities, we will not be bridging the gap. So this is strongly recommended. And I love engaging more TB survivor in this movement. Unless this movement is not going at the grassroots level, we might not be getting the result which we are looking for. Thank you.
Sorry,
You're on
I was
mute.
muted. Yes, thank you, Purvis. This is an absolute call for action, and I really appreciate that you took this voice today forward in our panel. And we're looking forward to you and many more of the TB survivors to actively engage. We always create space, and we will look forward to having you back. So I would like to add my thanks to all of the panelists. Wonderful moderation, Jen. Thank you to all the private providers who made time out of their schedule to advocate. We heard your voices. We're going to further advocate. There's many good quotes that we can use for global media, social media. We will definitely be doing that. Thank you for your time, for your thoughtful actions, and let us be loud. And I fully agree, this is a year of hope. These regimens are giving hope. Let us make sure that we can actually get some right noise around that. With that, I am going to just put a quick poll up for those who are interested to give us some feedback. I would like to thank everyone for your time, everyone who was present. We will make the recording and the report available to all of you. It's going to be on our network. Join if you're not a member yet. And look forward to seeing you again next month. There will be new webinars, and we will be posting everything online. Thanks, everyone. This has been wonderful, and wishing you a happy evening and a good rest of the weekend and a good rest of the day for those who are. Goodbye. Thank you so much.
Thank you, everyone. Thank you for this wonderful opportunity.
Thank you.
Thanks. Bye.
Thanks very much.